afternoon, everyone. You are looking at a screen on which, unfortunately, my face is not there. We're having a slight technical hitch with a new laptop. So what you're going to hear is me, Geraldine Strafty, your host for this Challenge Your Behaviour conversation, talking to our very exciting panelists about their personal and professional experiences of COVID. The reason we've called this the Challenging Conversation series is because we try to look at different perspectives of COVID. For some people, COVID has actually felt okay. For many other people, it's felt really challenging. If you're a frontline professional, if you are a service user who's not been able to find the support you need. So last week, we focused on inpatient services being at the very front line, at the heart of people coming in, feeling acutely unwell and in distress with both the physical and the mental health symptoms of COVID. Today, we are looking at the community, people that work in the community. And we are joined by one of our wonderful SLAM ex-governors and expert by experience and recovery college trainer, Catherine Grant, Julia Ungunia, who is one of our local homegrown in the boroughs, our junior doctor, who also runs her own charity called Colourful Minds. And Julia is going to talk to us both her personal experience, but also the whole issues surrounding the extra additional stresses of coming from a BAME community during the COVID period. And then we've got Martin, who's a junior doctor who can tell us what it's been like from the health medical side. And finally, absolutely last, but definitely not least, is Councillor Ed Davey, who is an amazing guy, who is a local councillor in Lambeth, has been responsible for commissioning mental health and alcohol services, who completed his Masters in Public Health at the King's Fund, at King's last year, and is very, very exercised by the impact that COVID had on his population in Lambeth. The format of today is each of our fabulous panelists are going to talk about their experiences, and then we will start having the challenging conversation about the differences, and we will think about the messages we want to send right up the chain to government, to local leaders about what would we do different, what have we learned this time in COVID that we would want to do different, whether we have another pandemic or whether we have other very, very different contingency crises. So I'm going to start off by asking Ed, are you ready, Ed, to tell us what it was like being a councillor in Lambeth in one of the epicenters of COVID during the recent acute stage of the pandemic?
Yeah, thank you, Geraldine. I'm as ready as I will ever be. So I'm Ed. As Geraldine said, I'm a councillor in Lambeth, elected 2010, the first time. And I started the pandemic as cabinet member responsible for health and adult social care, a job I've done for the last 2 years. So as Geraldine said, so in charge politically of commissioning and providing services around public health, but also coordinating with primary, secondary and tertiary NHS and other services, and also adult social care. So I started the pandemic in that role, but then in late April, the leader of the council moved me to being responsible for children and young people. So it's been quite a busy few months, as you can imagine. So at the beginning of the pandemic, we had to set up a hub, which meant a phone line accessible to all of our residents. Every local authority had to do that, and then provide food and other essential items via a delivery system that we coordinated. Our particular centre was at Brixton Recreation Centre, where we were able to put together food and other essential item packages and delivered it by cargo bike. And we were reliant very much on our excellent partnerships with our business improvement districts to provide us with food. Our voluntary sector were fantastic, and it really demonstrated to me the value of having really good relationships with your residents, with partners in the voluntary sector, in the community sector, in business and in the NHS. And what we found was that there was a huge amount of need. We've delivered about, I think it's about 13,000 packages of essential items to our residents. And as we've seen throughout this pandemic and previously, for those of us who've been paying attention to health inequalities, poverty is the #1 driver of poor outcomes. Unfortunately, we've seen poverty rise over the last 10 years, and that drives poor outcomes, and particularly in boroughs that SLAM covers. There's a very clear, if you drew a Venn diagram of our Black, Asian and minority ethnic population and those in poverty and those experiencing the worst health and other outcomes, those 3 circles in our Venn diagram that I'm imaginarily drawing now would closely correlate. And that is for reasons, hardly any of them are to do with genetics, nearly all of them are to do with structural racism, and they're to do with our failure collectively as society to deal with things like the structures created and the attitude and the culture created by things like the transatlantic slave economy. Now, that might seem like a distant historical past, but the only way that you justify dealing in human beings and making money from their pain is to dehumanize them. And unfortunately, we have not recovered from that. And so anti-Black racism that stems from that disgraceful period in our history continues to permeate through the way that we treat our Black family, friends, colleagues, whether we like it or not, whether we do it inadvertently or not. And I'm just as guilty as anybody else of doing that. So I think what the last few months have shown me and others, clearly through the Black Lives Matter movement and the way COVID has disproportionately impacted those communities, is that we really, really do need to address the inequalities in our society, in our boroughs, in our workplaces, and we need to do that by addressing the racism that permeates all of those environments and dealing with poverty, which, as I say, intersects very closely with racism and other discrimination. So I think we have an opportunity. And as I always say to my 12-year-old daughter when she bears about Brexit or Donald Trump or climate change, you know, when I was a kid, the equivalents were apartheid in South Africa, the Irish situation where there were bombs going off in the streets of London and other places, and there was the Cold War, where I thought genuinely as a kid that I was going to die in a nuclear conflagration. And one way or the other, imperfectly as they did, they all got sorted out. They all improved, and improved by us talking to each other, by campaigning, and by addressing things honestly and dealing with them. And now we have our challenges are intersecting around climate change, around inequality, around racism, around nationalism, and around poverty. And we need to deal with them, and we will deal with them. And so I hope now I'm in the children's brief, that children like my daughter and others, and we can support them in this, can work together to address the underlying causes of the causes, as Professor Sir Michael Marmot, your favourite, Geraldine, always says about what drives the illness. Anyway, as a typical politician, I've talked for far too long. I will shut up and allow others to speak.
Ed, absolutely fascinating, and you have beautifully set out for us what it was like to be somebody with a responsibility for very, very many people in the borough. And that was one of the themes that came up in last week's challenging conversations, was people in leadership, if anything, with what was happening, feeling that it was so difficult to get it right. It was so difficult to know what was the best thing to do. So thank you very much for that kind of really interesting introduction. If I now go straight to Martin, a GP at the front line in COVID. Martin, what was it like for you, that acute phase, and what's it like continuing?
Right. So, hey, hi, Martin Yu. I'm a GP in Southwark. I have been working in my own practice for the last 23 years and have actually probably seen quite a few changes in how we deliver patient services over the last few years, but probably never as quickly as it has during this pandemic. I think the changes put in place were almost overnight, and how we had to actually work with patients. For example, we had to switch over to virtual consultations, literally, just like that. And that in itself was very challenging because a lot of patients needed that face-to-face contact. You can't take that away. Sorry, was I muted just now? Sorry, I just had a message to say I was muted. Can people hear me? Oh, thanks. Okay, cool. So I'm not repeating what I said if I was muted. So working with a COVID hot hub that was actually set up really within the week, where patients were actually seen in a very safe venue. And that in itself was very interesting because I don't think we've ever had black cabs pick up patients, bring them to a clinic, and actually send them back home if it was appropriate, or actually transport them to the hospital immediately. The response time, in fact, was quicker than LAS. I mean, I do not diss LAS. They're amazing, but they were so stretched. We had to do our bit to actually support. So it's not about actually just working in primary care, it's actually working across the whole system. Now, a lot of people, and myself personally, a lot of people actually been affected by the pandemic itself, by the virus, by illness, and how we actually take that experience and see how we can actually deliver services better in the future. I think this is what we need to actually focus on. There is so much that we've actually learned that we can do and do safely. And over the next couple of months will be quite interesting to see how services change. No one will work the same. They probably shouldn't work the same because there are a lot of good things that came out of it that in fact were more efficient. People holding on to things that they've been doing for so long, thinking this is the way to do it. Actually, welcome to the 21st century. And there are things that we could just literally need to carry on and evolve a bit more. And hopefully with conversations like these, and again, talking outside of your own teams, it's not just about primary care. It's not about community services. It's not, I shouldn't say it's not about SLAM, because actually you guys are hosting this, but it isn't just about mental health. It's actually about long-term conditions. It's about the council. Everybody really needs to start thinking, let's work together on this. And hopefully, because of this bloody awful pandemic, we've actually been pushed and nudged further, faster to work together. I think I'll shut up now.
I think we might have lost Geraldine. But I remember she was going to ask me to go next, wasn't she? Sorry to do that. So hi everyone, my name's Catherine, and I'm going to struggle to follow Martin and Ed because I think my experience is much more mundane, if you like. I'm certainly not in a position of leadership or anything like that. But I have been involved with SLAM for some years now, first as a service user and then as a governor. And then now as a member of staff, which has been fantastic. I work as a peer recovery trainer in the Recovery College, which is attached to SLAM. And for those who've not done a Recovery College course or anything like that, we are open, well at the moment, we're open to everyone, not just service users, carers, staff, volunteers, but anyone can access our online courses. And I guess the first thing I'll talk about is that experience of having joined the team relatively recently. I joined in January in the office, working part-time and found my feet very quickly. Lovely team, loved my colleagues. I loved working at the Maudsley, going in with my staff pass, felt really nice. And then COVID crept up on us, and all of a sudden office was closed, and we couldn't teach anymore. We couldn't do our classroom-based workshops, and that was our main product, was doing workshops with anyone who needed it, service users in particular, on everything from the impact of addictions on mental health, the sort of introduction to recovery courses we run, understanding various mental health conditions, that kind of psychoeducational approach to long-term recovery. Long story short, we got our act together pretty quickly. I'm really proud of the team and what we did and how we pulled together. We basically moved online. We got into Microsoft Teams, other platforms are available, and we started delivering what we could in webinar formats, and they've been really well received. And amazingly, we've been able to reach a much wider audience than we can do face to face. So I think the lesson longer term is both is needed and welcomed in different populations. For many of us, it's a lot easier to log on onto a Zoom type call than it is to trek across town to a classroom and find childcare or farm out your other responsibilities in order to attend the class. So I think we'll keep on doing that. I hope we will. It's been tricky at times balancing work at home with teaching at home. I have an almost 8-year-old son. He's on his holidays now, but we had to do the end of year 2 at home. I think, like a lot of women, the childcare / homeworking, homeschooling has fallen predominantly to myself, and that's fine. But I've been really interested to read the sort of inequality aspect around women and the way they've been affected primarily through the different demands on them. What else was I going to say? In terms of mental health, and I mean, speaking for myself, I've been fine. We've coped. It's been stressful at times, but I always go back to how lucky I am to have a supportive family, not just my husband, but my parents as well have been great. I know a lot of people who've found themselves incredibly isolated, like really isolated, and that is no good for anyone's mental health, esteem, feelings of self-worth, self-compassion. When you are locked inside with your own thoughts can quite quickly become negative, repetitive, and make you doubt yourself. So that's something that I've come across a lot within friends and family. But also on I volunteer for a crisis text line, which is like the Samaritans essentially, but text message based, called Shout. And I've noticed there a huge increase in the number of people texting quite late at night who are really suffering the impact of lockdown in terms of not being able to reach their friends, their loved ones, missing people. So yeah, isolation and loneliness, I think, is going to be a real challenge to overcome. And I think that was all I was going to say. But yeah, just juggling motherhood, work, getting used to the new way of working has all been a bit of a challenge, but I count myself lucky that I've been able to fit everything in so far. That's me.
Catherine, thank you so much. That's absolutely wonderful, as always, getting to the absolute jugular of what it's like for experts by experience. And we are obviously still celebrating your appointment to the Recovery College, and I'm sure joining your classes would be a real treat for anyone. And if the intention is to do more of them virtually, I think that is absolutely the way to go for people who are digitally included. One of our other speakers who will be joining us in a bit, Julie Drive, works with homeless people. And the thing that Jenny wants to particularly focus on is, what about the people who are digitally excluded, who aren't in the generations that find digital easy, who don't have access to a phone, who are incredibly impoverished, who usually we in mental health services need to go out to them into the communities, often the forgotten tribe of people. But thank you very, very much for that fabulous summary of your experience. Very inspiring, Catherine, thank you. And Julia, can I turn to you now? Tell us about being a junior doctor, being someone from a local community, someone who runs charities, who's managed inspiringly to galvanize other fellow psychiatrists and psychologists from SLAM to go out into communities and provide education about mental health. What's it been like for you?
Hi, so my name is Julia. I am a general adult psychiatrist, and I am coming to the end of my training, so about to enter the final year of my training as a specialist registrar. I've worked at SLAM since 2013, and I've grown up in the local area. I founded an organisation called Colourful Minds, which Geraldine has mentioned. We're made up of minority ethnic, mainly Black and Asian mental health professionals, and we do outreach to communities through workshops in schools and churches with the aim to reduce stigma surrounding mental illness in these communities. We do this by educating people and trying to bridge the gap between mental health services and people that are adversely affected, people that have the poorest outcomes for mental health services. And hopefully we present a relatable face by showing people that look like them, understand their experiences, understand their cultural context, their spiritual beliefs, the food they eat, things like that. COVID it's been a really scary time. I think personally, initially I felt quite scared, more so for elderly family members, for friends that I knew had comorbidities such as sickle cell. And I felt afraid as more and more information was emerging that people from Black and minority ethnic backgrounds were more adversely affected. I had a lot of concern from relatives and friends reaching out to me, being aware that I was a frontline worker, and more information started to come out in the media that frontline workers were dying, and particularly people from Black and minority ethnic backgrounds. So I did feel quite personally afraid for my safety. At the time, at the start of the pandemic, I was working in a specialist anxiety service, both inpatient and outpatient. And actually, the 8 months prior to that, I had spent reflecting on perceptions of threat to safety, on tolerating uncertainty myself. So it was an interesting time to be working for that service. Unfortunately, we had to close the unit because that environment was around discouraging people from engaging in safety behaviours such as hand washing and avoiding touching things and avoidance in general. So it made it really challenging for us to continue the work that we were doing. Whilst we closed, I felt really quite bad for our patients because they were in the middle of treatment and at one of the most stressful and difficult times were sent back to overstretched community services to continue sort of working on their difficulties around mainly OCD and body dysmorphic disorder. So that was challenging. So that after that I was redeployed, and prior to being redeployed, I was, as a junior doctor, concerned about the impact on my training. It wasn't clear what was going to happen. I was anxious about potentially being redeployed as a medic to a general hospital, but also a little bit excited at that prospect, I guess. Whilst mental health services are frontline services, we felt frontline in a different way. And initially, I noticed personally when I was working out of hours that there was a reduction in presentation to mental health services during that time. And the focus was more on physical health. So the idea of sort of being stuck in and rolling my sleeves back as a medic was exciting but scary. So I was redeployed to the mother and baby unit, which was an inpatient service. And at the time I started there were many staff and patients with suspected coronavirus. So I became quite afraid that I might get coronavirus myself. eventually I think I became a bit more desensitized to it, but through the work that I've done with Colourful Minds, we've had to adapt the way that we work. We usually do workshops, we go out to communities. We haven't been able to do that, but we've been able to utilize social media platforms and other things to do sort of online webinars and host live interactive events. And as Catherine mentioned, this has been, I suppose, a blessing in a lot of ways, because we've been able to reach people that we might not have been able to reach. We've been able to canvass feedback about people's experiences. What I personally gathered is that there was a lot of anxiety and fear. I think that's true in any community, but particularly within the Black and minority ethnic community. A lot of mistrust and fear. People wanted answers to why Black people were being and minority ethnic people were being so adversely affected. And I think Ed touched on this. He's spoken about how structural racism has really contributed to people from these communities being disadvantaged and having health inequality. So we have done what we can to try and support people by listening to them, by engaging them and talking to them. I think superimposed on this was the death of George Floyd, which reignited the Black Lives Matter movement and brought focus on this in the UK in the way that I haven't personally seen before. This was a really traumatic experience for particularly Black people. And I don't know if it was the combination of lots of people being in a lockdown and the focus and attention going to this thing that had happened and coming to race. It was a really difficult time. I think I wasn't prepared for how I would be affected personally. I wasn't prepared for how everyone that I spoke to that was Black felt about what was going on. And it highlighted to me that real change needs to happen within health, particularly within mental health, particularly within SLAM. I have, as I said, I've grown up in this area and it's very densely populated with ethnic minorities. And anyone that works in SLAM will know that a large proportion of the workforce are from ethnic minorities, and most of the patients are from ethnic minorities. And it's no secret that people from these communities have poorer outcomes and poorer experiences with mental health services. And I felt more than ever really passionate about trying to change that and trying to see what we can do to address these issues. The other thing I wanted to mention about is the changes that have happened in the way we work. And one of the fantastic things that have come out of the lockdown is the use of platforms like Teams to have twice weekly broadcasts from the leaders of the organisation, because it allows us to, it makes the leaders more accessible in a way they haven't been. It allows us to hear from them, and it also allows us to be heard by them and to challenge our leaders to ask the questions and hold them accountable, which prior to this I had never felt able to do. Yeah, I'll stop there.
Julia, absolutely fantastic. Total tour de force. Thank you very, very much indeed. And really, really interesting to hear your perspective, which is some similarities to what Dr. Laddie Smith talked to us about last week and something different. I suppose this is probably a good point to introduce the fact that on the board of SLAM, I'm one of the non-exec directors. Every single time Mike Franklin, who is from a BAME community and who is a fellow NED, has very, very clearly said exactly what you've said, Julia. We have to understand that so many of our patients and so many of our staff come from local BAME communities. And he is very passionate about how we shape our services going forward to change that. And the really good news for all of us is we now have a friend in high places, because he was just appointed this week to become one of the key equalities champions in NHS England. So we have a friend at the top table if we have lots of really good solution-focused suggestions to make. What I would love us to talk about, the challenges really, is of providing care to people with mental health problems during this COVID crisis. And if I can go back to you, Martin, because what my GP family members and colleagues tell me is exactly as you've said, COVID has made primary care think a lot about who do you need to see, who could be seen by virtual means. One of the things that I suppose I wanted to ask you about is how much do you think of primary care could be different if people with long-term conditions, there was a real focus on giving them the equipment and the information and coaching to do more self-management? That's one of the things that I know in Northern Ireland has been very seriously considered, is how many people with diabetes could actually, if the equipment was given to them, so it's not a prescription, it's a prescription for equipment and training, would that work? Would that work for us in our highly deprived and often perhaps people with lots of different languages, communities locally?
Actually, really good question, and the answer probably is yes. How big an impact it would make would be well, I guess it's challenging to actually sort of get the equipment out to the patients and getting them to start using it and taking it sounds a bit awful, this, but getting them to take responsibility for their own care. I mean, a lot of times what we see in general practice is that people like to talk to the GPs, like to talk to the healthcare workers, like to talk to the nurse specialists. And I think the reason's twofold. One, they theoretically should be the first protocol and the expert on giving advice regarding their long-term conditions, but also it's that face-to-face contact that people like. And it's a bit of a change in people's mindsets and to take back responsibility. So I don't let's just pick up the phone and call someone. What can I do for myself? And that's probably going to take time. We are seeing it definitely over the last couple of months. And people, rather than saying, I need to make an appointment, can I just have a telephone consult just to actually catch up, touch base? This is what I'm doing. Is it right? And people seem quite happy with that. So it's already happening and we are seeing it. But for them to actually be expert patients in their own care would be amazing, because we can bang on about how healthy lifestyles are important, to stop drinking, stop smoking, eat better, do more exercise. But unless people actually have a mindset that they want to start doing that, it isn't going to happen. So people need to take charge. And I think that is probably more important than getting the equipment out to them. When they're ready for it, by all means, great, send it out and we can prescribe it. And I believe they are already doing certain parts of the UK. For example, you can actually prescribe scooters. And in some areas, there's actually a trial coming up just to get people out of the house more. So in a roundabout way, I would say yes, really, really good idea. But the challenge would be to getting people to take responsibility and start thinking about doing it themselves.
Catherine, challenge to you in the Recovery College is helping people do self-management. Is that a realistic objective for the future of healthcare? Helping people to be more equal partners in their own care, but also kind of more determined about their own care and to get the help they need. To people like, you know, GP or care coordinator, they could ring up and say, can I just check with you, as opposed to, can you help me or can you do it for me? What do you think?
Yeah, I think it's a really worthy ambition to have, but it is an ambition, and I think the reason harks back to what Ed was saying right at the start, which is we can only empower people so far with their, you know, taking charge of their mental health and, you know, being an expert patient and, you know, being their own care coordinator, if you like, if they're in an environment where they feel safe and non-traumatized and able to, you know, it's a hierarchy of needs, able to have, you know, a warm, safe, decent house, live in a community where they're not suffering from violence, abuse, discrimination, racism, any form of victimization or discrimination at all. And, you know, then you might add in education and all the rest of it, decent employment prospects, that's just as important as any form of mental health education that a recovery college can provide. I mean, obviously, I'm glad the recovery college exists, and it's great that we're able to provide that for people who are fortunate enough to be in a position to use it. But it's, as any frontline healthcare worker will tell you, it's really hard to discharge someone back into their community to manage themselves without, intensive support if they don't feel safe and secure. So I always try. I mean, it's hard sometimes because I can easily lose sight of that in my enthusiasm for the education that I do, the mental health first aid courses that I run, all the rest of it. But I'm constantly trying to remind myself that that's like a nice layer to add to somebody's recovery once those basics are in place, if that makes sense. But I feel for those who are able to access it, it's brilliant. And it certainly, for me, it was a turning point in my recovery. So I had postpartum psychosis, and I was a patient for some months in the mother and baby unit that Julia mentioned. And for a long time, the depression that lingered afterwards meant that I felt I was very much the patient, and the staff were there to fix me, and I couldn't do anything for myself. I wouldn't even go to the bathroom, that level of dependency on staff. And it was only when I suddenly realized that actually I was the person in charge. I had to do certain things to get better and also help my baby out as well. That was the point at which I recovered. Had little to do with specific treatment and all the rest of it. That was the acute phase. The long-term recovery was empowerment. And hence why I do what I do. But yeah, we can empower people with psychoeducation and tools and action plans, crisis management, techniques, advanced planning, directives. We can give them those things, and we can empower them, and we can work very collaboratively with service users and carers to make that happen. But I think we have to remember there's an awful lot of people in our communities that they just can't access that yet, because of all the trauma they're living through.
Catherine, would you be surprised if we were to say that the one bit of data and information that is not available in national reports, so we have lots of national reports about the rate, the numbers of people being referred into mental health services, the number of people being seen, whether it's in 1 week or 2 weeks or 52 weeks. But we don't have anything routinely that says exactly what you're saying is the utterly critical point. So how many of the people who come seeking help have got stable, warm, affordable, safe housing, have got the level of support and backup for what they need, are not one of the 67% of people who end up being admitted because they live on their own and they have absolutely no support. So would you be surprised if I were to tell you that at national level, we really don't have a data set that gathers that information routinely? And really surprisingly, many mental health organizations, and I think probably primary care, Martin, don't gather that routinely. So in many ways, what you're saying is, without that fundamental knowledge about the social determinants that could either prevent the onset of mental ill health or the recurrence of it, we really need to get our act together around that.
Yeah, thanks, Geraldine. It is shocking, and I'm not surprised, but only because I remember sitting in a board meeting when I was a governor, where I think one of the data sets being presented was something like the number of people, percentage of our inpatients at SLAM that had a next of kin or a family member or a friend listed in their notes. And it was shockingly low, like 25% or less, if I'm remembering correctly. And I mean, it's overwhelming, I think, actually, for staff when they're trying to help people in that situation. But yeah, something is obviously gone very badly wrong in a system which doesn't gather that information as a starting point and then do something to try and address it.
Thank you. And Ed, as a commissioner of mental health services and a commissioner of local government social care services, what do you think is the role of information systematically gathered? And if I look at our joint strategic needs assessment across Lambeth, Southwark, Lewisham and Croydon, I am quite struck by the lack of information about the social demographics, the kind of the social underpinning firm structure that people need. I don't find it very easy to find. So how can we chat, and including ethnicity? I mean, 30–40% of people, there's no proper or robust coding on ethnicity. So what would you as a commissioner think we should be doing about that?
Thanks, Geraldine. Well, so for me, there are two parts to public health, and that's the scientific data, the information we have, and the best evidence. And then there's the communities themselves. And for me, one part doesn't really work without the other. So I remember doing my degree and learning about how the Latin American community in the southern states of the US had much higher rates of injuries and fatalities from road traffic accidents, and the public health people in Arizona and states like that couldn't understand it, so they sent out these researchers to spend time with the Latin American community in those states and in their cars, and they found that lots of them just didn't use seatbelts and child seats in their cars. And when they talked to them about that, most of them were Catholics, and they said, oh, it's in God's hands that whether we have an accident and whether there's a poor outcome. Obviously, they didn't use that terminology, from the accident. And so they thought about how they might address that. And they talked to the community and to the priesthood, and they talked about how they might, they got the priests to extol the virtues of wearing seatbelts and using child seats in cars, and they provided these cheap or free, and then the priest would bless them and endorse them. And the bottom line was that now those communities in those states have lower rates of poor outcomes from road traffic accidents, because it's become a kind of social norm within that community. And the point is that requires the scientific data about the value of using a seatbelt and a child seat, and doing the research, and then getting acceptance from the community. So it's just one example of how I think, you need science and you need community. And we don't have great data on some of these things, but we have some reasonable data. But I mean, me and some colleagues did this, which I can post in the chat, which was about, it's called From Surviving to Thriving, and it was the Lambeth Black Health and Wellbeing Commission in 2013 that looked at the disproportionate number of our Black residents in the severe end of the mental health system. And we co-produced some ideas around preventing mental illness with our Black communities, providing better access to more appropriate treatment, and to improving patient experience. And what's incredible is that even though that's nearly a decade old, we found at the time that the ethnicity recording data within SLAM, and not just SLAM but other places, was really quite poor. And we're still having this conversation about ethnicity recording within SLAM and other places as well. So we need to get much better at that, and we need to also, as Catherine said, it's not just the data, but it's like Catherine, I've had an experience of mental ill health. I'm a recovering alcoholic. I happen to have really good service from SLAM, and cognitive behavior therapy, for example, worked really well for me. But I could draw on lots of privilege, unearned privilege, because of my whiteness, because of my middle classness, because I've got educated, supportive parents and all the rest of it, that I'm acutely aware that other people, through no fault of their own, cannot draw on those wells, and therefore have a less good experience of things like cognitive behavior therapy. So it's understanding the context of things and supporting people. I'll give you one other example. My kind of deputy in the council is a Black guy who's a bit younger than me, who runs, among other things, Brixton Soup Kitchen, and he established Brixton Soup Kitchen. And he's a Black guy, he's a trained teacher, he's got a PhD, he's got no criminal record, but he has been stopped and searched more than 60 times by the police. He's lost count, actually, of how many times he's been stopped and searched. Now, we know that our Black male population has much higher rates of paranoia. I'd be paranoid if I'd been stopped and searched 60 times and was followed around shops all the time for no good reason. I've never been stopped and searched, and the only difference, actually, I have been arrested for being drunk and disorderly when I was drinking. I've got a longer criminal record than this guy, and he's been stopped and searched 60 times and I never have. So So we've got to think about, you know, those social determinants, that racism, that poverty, that lack of resource, that through no fault of their own, people like Hashi, who's perfectly mentally well as far as I'm aware, is at much greater risk through no fault of his own because of his characteristics. But in order to understand that, like you say, we need to measure and understand the characteristics, and then we need to think about the evidence-based ways of working with those communities to address them in a systematic way, because it currently is it's so loaded against people in those communities, and then we're surprised that they fill up our hospitals and don't have the same outcomes. Well, you know, it's obvious, isn't it? I mean, it's really clear why that is.
Yep, definitely. Thank you. Julia, what solutions? Because we've had some really upbeat conversations in this forum, really good ideas, really wanting to do things forward. And then we have some big chunky problems, which I've never, I suppose in my entire lifetime, have been recognized. Poverty kills, deprivation kills, children brought up in poverty, children brought up with adverse childhood incidents become the people that most need services going forward. What solutions would you, as a young Black leader and a doctor, feel we should be doing if, for example, there was to be another spike of COVID in this country? What would be the big ideas you'd want to see happen quickly?
So the things I would like to see happen anyway are transparency from organisations. So transparency around the experiences of Black and minority ethnic people when they come to these organisations. I think that is the beginning of a resolution so that people can start to trust these organisations and access help. I think that's one of the things. We need representation at senior levels of leadership in these organisations that, for the most part, are beginning to happen, but we need much more, because there is a wealth of knowledge and experience that comes with just being a Black person from this area, from this community, that is just not being tapped into and utilised. And just being able to really understand people can happen from just sharing some of those cultural experiences. I think we need to be more proactive about engaging people from these communities, i.e. more grassroots organisations that go out and canvass the opinions and the feedback of people from these communities, and also show representation to feed back into how we do things. I think that would be a huge way forward if we could start to get those things into place and build the trust of many of the people that are adversely affected. Because if there's no trust, there will be no engagement. And honestly, my experience of talking to people in these communities is they are in a lot of ways right not to trust us, because it shows, you know, there's evidence to show that people have bad outcomes when they engage with institutions like mental health services. So we need to build that trust by making some real changes and acknowledging how we failed people.
Thank you. Martin, what's your view as a local GP in probably one of the most deprived areas in the entire country? What's your big idea? What would you absolutely want the Prime Minister or the Secretary of State or the Board of SLAM or the Board of the CCG to think we should do if a second wave were to hit? Easy question.
Okay. So I'll start off by being very inappropriate, is to say a lot of times we actually hear in the community is not enough money, not enough time, not enough people. So I think if we were to be hit by a second wave, I mean, what I'd like to do is actually concentrate on mental health, because there's so many aspects of healthcare that we could talk about and that I'm quite passionate about. But if I'm specifically thinking about mental health, general practice has 10 minutes per patient. across the board for a lot of practices. That's what we got. And it's not an excuse. It's actually just a bullet point. That's how it's been working. We need to change that. But in order to do that, we actually need to have more people in place to be able to deliver the work. It doesn't have to be a GP. There are loads of other people out there that are equally qualified to give advice. Clinical pharmacists, advanced nurse practitioners, equally important. People need to access communities and the services in the community. Your local pharmacists, our two local guys are amazing, really. And I work in Peckham, just in case people are wondering where I work in Southeast London. And for mental health, when patients actually call up and they're asking for help, asking for assistance, of course, we can actually signpost them to services. But I think what they need is in the first 30 seconds when you're talking to them, almost actually, they need to trust you. If they know you, great. I've known a lot of my patients for 23 years, but if it's a newly registered patient, I need to make sure they actually trust me within 30 seconds. Not an easy task, and often you can do it and sometimes you can't. Hey, you know what? But whatever services we offer to people needs to also be reactive. And we have a really good, to be honest, I think we have a very good relationship with SLAM and our local community mental health teams. We can always pick up the phone, talk to people, but I often actually sort of feel that they're as stretched as we are. So if a patient actually calls up the one-stop shop telephone number to self-refer to talking therapies, they need to be able to get through. The person on the other side of the line needs to have the time to actually talk to the patient to find out what it is that they really need. So I think if we take a message up to Prime Minister or NHS England, funding needs to actually go to people that work at ground level, not actually more managers. And like I said, I'm being inappropriate, but hey, that's a very personal view.
No, that's great. And as Julia said, one of the first ways to build trust is to be transparent, open, and keep saying we're trying to find solutions here. So no, that's really helpful. Thank you. I loved working in Peckham. When I was a consultant at the Maudsley, we worked out of a converted curtain shop in the heart of Peckham. And it's kind of relevant to this conversation because it was in a certain outreach. And one of the reasons we moved out to Peckham is because we said we need to be right in the heart of the community of where people are, because we'd done a mapping exercise of who used the services, which are on the Maudsley site then, and the only people that used the services lived within a 400-yard radius of the building. Once we moved out into the heart of Peckham, we didn't actually have to do much in the way of assertive outreach because people came to us because it was easier, and we were right beside the snooker hall, which I'm sure was enough as well. So Ed, what's your big message? And don't make it political, make it practical. What's your big message to kind of government about if there was to be a second wave, what would you want to be different for your constituents? Lambeth.
Well, as you know, Geraldine, I love the World Health Organization's tripartite model of prevention, which looks at social determinants, so like poverty and racism and inequality, as I've said. So let's address that. Let's have a proper anti-racist policy. Let's have a proper poverty reduction strategy. I'm the statutory lead for children's services in Lambeth, and I read my statutory responsibilities. I actually read a slightly out-of-date version that included my responsibility to measure and have a strategy to reduce child poverty in Lambeth, as every upper tier local authority had the responsibility for. And I said to the officers, where is our strategy? Why aren't we doing this? It's the law. And actually, and I'm not trying not to be political, in 2016, the government changed the law so that I don't have that responsibility anymore. No local authority or central government has to measure child poverty or have a strategy to reduce it. They actually amended the Child Poverty Act 2010 in 2016 to remove that duty. So the first thing I would do is have a strategy to reduce child poverty, because like I say, that's where a lot of, if people have financial resources, then they are better able to cope with a whole bunch of stuff, including COVID and mental illness. And for every £10 of increased child benefit, you reduce child poverty by 5%. That seems to me like a very sensible starting place to invest. On the second part of the WHO tripartite model is environment. let's create environments that support people's mental health, access to green space, active travel, not being surrounded by 24-hour off licenses and really unhealthy fried chicken shops. I'm not making cultural judgments about fried chicken, but let's try and give people healthy options and not have kind of the poorest people being denied the choices I take for granted, and live in healthy environments where we can cycle and walk and have green space and have healthy food. And then the third bit, and it's third, is personal behaviours and characteristics. So let's support people with the tools they need. I met a young man, a young black guy, who's one of my children in the sense of being a corporate parent, and he said to me that he has anger issues and he's had some difficult experiences, and he doesn't want to be pathologized and given a diagnosis and medicine, although that I recognize that is appropriate for people sometimes. He wants support to deal with his anger. Now, he's been traumatized as a child. It's completely natural human reaction to be very angry, and that comes out in some difficult behaviors, but we need to support him and others, A, to avoid having the traumatic experience in the first place, but B, to be given the tools, like I was given the psychological tools to manage my desire to pick up a drink of alcohol, right? That I have some psychological tools that I can use. We need to support people with appropriate, culturally appropriate psychological tools to understand how to get the best outcomes for them and their families. I love working at home because I can pick up props that I can't do in the office, like books I'm reading at the moment. So this is a book about the Harlem Children's Zone, where they equip parents culturally appropriately, the Black community in Harlem, about the science around child development. And actually, what the book says is that these were the families that never got this information that parents like me get. And actually, when they get the information about brain development and how it's important to talk to children from the very beginning, they grasp it and they use it and they get better outcomes. But we snobbishly say, oh, they wouldn't understand it. Well, they do understand it if you give them the opportunity and it's presented in the right way and presented by people who look and sound like them, just like Julia was saying. If I go and lecture a bunch of Black working class people, they're not going to be very receptive to my message. But if Julia, who grew up on the Aylesbury estate and looks and sounds like people who could benefit from this information, they're obviously perfectly capable of learning from it. So those are my three things. Social determinants, let's tackle racism and poverty. Let's create healthy environments so that we make it easier for people to make healthy choices. And personal behaviours and characteristics, let's give them the psychological tools, the science in understandable ways from people who look and sound like them to make good choices. But choice is not an equal thing. Choice depends on our circumstances, so we need to improve the circumstances.
I think I'd vote for Ed as Minister for Children. Anybody disagree?
I am Minister for Children in Lambeth, that's all I need.
Can I just thank every single one of you panelists? Catherine, thank you as always for just such an amazing, grounded, constructive, solution focused. And thank you for telling your story as well. I always very, very much appreciate and learn and feel inspired by you. So thank you for agreeing to come on the panel today, especially on your holiday abroad. Martin, thank you so much. It's always great. I have a very warm heart when it comes to general practice. I think you do one of the hardest jobs in the world, but thank you again for your solution focus. Julia, we just need to clone you. It's quite simple. We could certainly sort out an awful lot of cultural issues if that was the case. And Ed, thank you very, very much indeed, and keep on being the Minister for Children locally. My grandkids will benefit as they are living in the local area, and I can hear one of them screaming outside my door as he wants my attention. So thank you so much, all my panelists. Thank you very much, Katie, Sean, and the wonderful team who've helped organize this. And thank you so much, people, for listening. Take care and have a great summer. Thank you.